The NF1 gene makes a protein called neurofibromin, and neurofibromin is called a tumor suppressor. And what that means is it controls the way that our cells grow and divide. It's lovely to see you all, and I recognise some of you, so it's lovely to see you all here again. So today I want to just go over some of the features of NF1 and how you and we in partnership are managing them. So your first starter for 10 is, how common do you think this condition is? Anybody want to hazard a guess?
1 in 3,000.
Whoever said that almost got the trip to Eurostar. Yeah, it's around, these days we say around 1 in 2,500, but you're very close and maybe right, but it's about that. So as you know, probably better than me, it is an inherited genetic condition, and that's because there are changes in our genes. Does anybody here bake cakes? I bake cakes. And Mary bakes cakes for us, our CNS, she's pretty good at it. So basically I regard the gene, because I'm a neurologist, not a clever geneticist, I regard it as having ingredients to make up a recipe, and that recipe is our gene, and it tells us how our cells should behave. And that's about as far as I go in genetics. And we know it's inherited. What's your chance of inheriting it if one of your parents have got it? Brilliant, you're too good. So the NF1 gene makes a protein, a bit like our cake, called neurofibromin. And neurofibromin is called a tumor suppressor. And what that means is it controls the way that our cells grow and divide. And all of us, you know if you cut yourself or bump yourself, your cells repair themselves because the cells are growing and turning over. But we've all got stop-start signals. And in NF1, the signals are there, they're just a little faulty and slower, and that's why your cells can form together to form lumps. So the way that it does that is to send lots of signals saying grow, stop growing, grow, divide. And the only way I can describe it is being like Clapham Junction. Has anybody been to Clapham Junction? Yeah, unfortunately is the word, because it is a signal hub, and it sends lots of signals for trains to go or stop going. Most of the time it's stop. But in a way, that's how I think about the NF1 gene. It's sending signals, and some of them are starting and some are stopping. So all I want you to remember is the red arrow, and that red arrow says MEC, and it's one of these signal hubs. So remember it, because we're coming back to it. So many of you will know more about the diagnosis than me. How many features do you need to make the diagnosis? 2. I'm afraid the Eurostar tickets have been sold out, but you might have got one. So obviously it predominantly affects the skin. Anybody can get a cafe au lait patch. It's the number that make the difference, and they're smooth and round, as you know. And you can get freckling not only under the arms, but in the groins, around the neck, and under the breasts. The neurofibroma I'm going to come on to, and these are the skin neurofibromas that I've shown you. And then at the bottom, the more diffuse neurofibromas, the plexiform. NF1 really affects the bone, and we'll come on to that a little bit later, but making it predominantly softer and sometimes more prone to fracture, and you can see the pseudarthrosis at the bottom. The eye, leash nodules, are just domed brown lesions on the iris, the coloured bit of your eye. Does anybody know who Leash was? He's a very boring man. He was a very overweight Austrian, And he got the Viennese Empire Medal for describing this, but he was a bit of a cheat because somebody else described it about 30 years before him. But we called them leash nodules after him because he was very good at promoting himself. And then, of course, you can get the optic pathway gliomas, which you see in the arrows. Those are thickened nerves. And as you have rightly said, there's a 50-50 chance of passing it on, so you can have family members affected. So there are other features of NF1, which aren't the diagnostic ones, but are fairly common. I'm quite short, so a lot of people are short, but in NF1, some people can be shorter. And you can have larger heads. Again, that's not restricted to NF1. I went round my male colleagues about 20 years ago, and I found all of them had very big heads. So, if you've got a big head, you are like a neurologist. Has anybody encountered xanthogranuloma, those yellow things? They occur in young children, maybe on the head or the trunk, and then they disappear. You may read that they're associated with leukemia, but that is wrong. We don't think that that is the case. So if you've read that and you've seen one of these, don't panic. They're harmless. Those very pale patches, instead of the café au lait, are also seen, and all that means nevus anemicus is a white spot. And angiomas are very common when you get as old as me, but in NF1, they can occur in young people, and we call them Campbell de Morgan because that's the person who named them, and they're tiny little blood vessels, and they're harmless. So some people don't have generalized changes. Some only have them in one restricted area of the body. And you can see these in one segment, a hand and a chest area. And then finally, my colleague and friend, Eric Lichius, who lives in Belgium, realized that people could have café au lait patches and freckling without neurofibromas, the leash nodules or optic pathway gliomas. And he realized that this was another type of tumor suppressor condition called spread 1. What's a tumor suppressor condition? Nobody was listening. It means that it controls the way your cells grow. It's the stop-start signals, yeah? So this was another one with stop-start. And they've got lots of the features with NF1, but they've got a different gene, a different recipe. So most of the time we can make the diagnosis by looking at people. So I thought, if you're managing your NF1, when would you have a genetic test, which is simply a blood test looking for the change in the gene? And sometimes that's when the diagnosis is uncertain. Has anybody encountered this? Somebody has. Yeah, so sometimes you may not have two of the features that are shown, or the doctors aren't sure you've got enough café au lait, and the genetic testing can be very helpful. And the places that do it are in Wessex, Manchester, and Cardiff mainly. So even if the blood sample gets taken in your local hospital, it will be sent to one of those centres. And the other time that you get it is prenatal testing. So it gives people a little bit, everybody's different, and some people don't want testing and some people do, but it gives you a bit more control over your pregnancy if you know whether your baby has NF1, and it's a very individual decision. I'm sure Mary will be happy, or Carolyn, to talk to you more about that if you wanted to know. So what about the complications? Well, I'm going to show you some of them. And many of you will remember that learning is one of the complications. And most people have a normal IQ. I mean, what the IQ measures is how good you are with practical tasks. I'm pretty rubbish. I've just lost my way on the way from the station because I couldn't read the map. So lots of people can have those difficulties. It also shows how verbal you are, and it's just one way of assessing people, but it is usually in the sort of low normal range. We do have people with NF1 who are lawyers and scientists and really high performing. So there is a range, but severe problems with learning are actually very rare. And then there are specific learning problems, which I'll come on to, and some behavioural difficulties, attention deficit, hyperactivity, autism, and the behavioural problems where you don't respond to social cues. So for instance, this sounds like I'm describing my husband. So for instance, I finish a meal and sit back having done all the meal, looking at him, hoping he's going to clear the table and do the washing up, and he just carries on reading the paper. So it may be that children in school don't respond to verbal cues because the teacher wants everybody to be quiet, but they don't do what most people do and pick up that everybody's ready to start. So you may get coordination problems. How many people here can ride a bike? How many people can't ride a bike? So I happen to be one of the few children born and brought up in Holland that falls off a bike. So many people can have coordination problems, visuospatial difficulty finding your way around, reading problems, writing and spelling. And I've given you an example down there. So there, people are putting, this person's put capital letters in different places and quite wide spacing. If you look at most doctors' writing, it's illegible. And some people have speech problems. So some people speak too low, some people speak too high, some people speak too rapidly. Some people have a slightly nasal quality, and some people have something called voice creak. And that is, if I can mimic it, if you're Dracula, they'll say, "I want your blood." So it's a slightly lower thing. I don't want your blood, by the way. So what would you do to manage it? Well, there are a lot of people here, and I know that Carolyn and Karen are trying to get more help within schools, but the mainstay is an educational assessment for children, appropriate school support. And then if people have quite lax ligaments or bendy joints, physiotherapy or occupational therapy can really help with things like handwriting. You may need some very specific treatment for attention problems, and that would be directed by your treating team. And if a child has some behavioural difficulties or mental health problems related to learning, the local CAMS, the mental health team, would be helpful. There are plenty of adults who have difficulty reading and writing, and it is still a stigma. We ask everybody in our unit if they can read or write, because if they can't, we're sending them inappropriate information, and our nurses do a lot of work. So there's adult literacy support, and of course psychology support, and the wonderful Nerve Tumors UK. So I said I'd come back to neurofibromas. Does anybody want, I've got a new trip to the Seychelles. Does anybody for Seychelles want to tell me what they think a neurofibroma is?
It's an overgrowth of the myelin sheath.
Well, you're very close. I almost had to fork out. So basically, they are lumps on nerve coverings. And all of our nerves have nerve coverings. Down at the bottom, you can see a wire, and it's got a plastic covering over it. Our nerves have covering over it. It's a little more sophisticated than plastic. Up on the left, that's a picture of one down a microscope. And the main cell is a Schwann cell. I'll give you a brief look at this man. He's the one who described it. He spent his life looking down a microscope. And the Schwann cells, we've all got them, and they wrap around a nerve, a bit like that wrap is wrapping around a filling to keep the nerve safe. And these lumps pop out of the nerve covering, and they contain Schwann cells. So imagine the Schwann cell is the strawberry. So there are lots of strawberries, but in addition to strawberries, there are other supporting cells. So if you have a schwannoma, a different lump is just Schwann cells, but neurofibromas contain Schwann cells and lots of other cells. But it's the Schwann cell that's sort of the major cell. So the thing to remember is they're lumps on nerve coverings. So you will know better than me, this is very variable within families. So some people get a lot, some don't get so many. And they vary, even the ones that are on the skin. You can see some can be pinky, some can be less colour. The ones where on the right are the ones under the skin, which can be firmer and sometimes painful or cause some tingling or numbness. And the one down at the bottom is this plexiform type of lump, which is, instead of just popping neatly out of the nerve covering, it goes the length of the nerve covering, and it may affect many nerves. So how do you manage them? Well, you obviously want to treat infection with antibiotics. Does anybody know how you would know you got an infection in your neurofibroma, the one on your skin? It might be painful, it might ooze a little bit, it might look inflamed. If our patients aren't sure, they sometimes send a little picture anonymously to our nurses, and they can sometimes help them out just looking at it. You can treat with all sorts of things like surgery, laser, electrodesiccation. Basically, they're all forms of cutting. And you've just had a very eloquent explanation about the role of psychology in appearance, and we use our psychologist Susie Henley to help people cope with the neurofibromas. And of course we link with changing faces and think about camouflage makeup. So surgery or laser isn't the only way forward. Concerned parents often ask me, trying to get me on their side, whether tattoos can make neurofibromas worse, and the answer is probably not. If you look at Elvis's V at the top on the right, you'll see a tiny neurofibroma, but by and large we don't see that. So if you're looking for my support, the answer is I can't give it. So remember that more diffuse neurofibroma, they're the ones that really cause problems that we deal with and our nurses deal with. They, as you've heard, cause problems with appearance, neurological symptoms, so that's pain or weakness or tingling. Sometimes if they're in the pelvis, they press on the bladder or the bowel. If they're higher up, they may cause a bit of problem with breathing or swallowing. They can bleed because one of those cells in the fruit salad that I showed you before can make these things bleed, and they have blood vessels that help them grow. And we mentioned infection. So do you remember Clapham Junction? And on that very complicated signal thing, I told you about MEC. And MEC is a signal hub. That means it directs signals to growth. And our colleagues in the States have used a drug called selumetinib. And it was first used in mice. They were bribed with a bit of cheese, and then they were given the drug. And then in children. And what they found was the drug was well tolerated. It gave some side effects, so gastro and skin, but it reduced the size of these big plexiform neurofibromas by at least 20%. So that's what we call partial response. And some people said it helped their pain, it helped disfigurement, and it helped function. So we have the drug available on a very, very restricted basis at the moment. It should be licensed in Europe, so Brexit is a bit of a problem in March. Will it be useful for everyone? Will it be used for adults? We're still not certain, but it is a hope, and it is gradually becoming available. The downside is there's a huge amount of and intensive monitoring. So some of these compress on the spinal cord. So if you were a fan of Superman, you will remember that he fell off a horse and he fractured his spinal cord right at the top. And so that was a real problem. He couldn't breathe because that high above the breathing muscles, and he couldn't use his arms or legs. And neurofibromas, so that big white thing, it's right at the top of the spinal cord. The spinal cord's in grey, running down, and it's squashing it at the top. And the person who had this got weak arms and legs and problems peeing, so they had to have surgery, and they've done very well since then. Not everybody needs surgery, so the appearances can look alarming and somebody can be running around, so you do need specialist teams that understand this. Now, I'm not going to dwell on this because you've had an eloquent talk just before mine, but I think cosmetic appearance is a big problem for all of us, because of the pressure from social media and the ability to, I tend to do this for myself all the time now that I'm ancient. You touch up your image to make yourself look better. But for those of us who are exposed to magazines and Instagram and Snapchat, there's this great pressure to look how society says we'll look. So it's a big problem. So I'm going to touch on malignant peripheral nerve sheath tumour. It's a difficult subject because nobody likes talking about cancer. What I can say is that it's unusual. And over a lifetime, so that's a whole lifetime, only 15%, so 15 out of 100 people will have this condition. So the rest of them will be fine. But it is worth knowing about because it's how you prevent it in some people. So our nurses and the nurses in Birmingham and Manchester and Oxford and Cambridge, all over, will be happy to talk to you if you have a neurofibroma that is unusual for you. Not the ones on top of the skin, but the ones under the skin or the plexiform ones. So if they get very hard, like a table, if they're growing quickly, they're not the size of a pea, as I've shown you there, but say they've grown to the size of a plum or an orange very rapidly, you must get it checked out. If you have neurological symptoms, or if you have persistent pain that's unusual for you, or pain waking you at night, or your bladder or bowel or breathing or swallowing change, and you know you've got a neurofibroma, that's a plexiform or a deep-seated one, that's the time to check it out. So I'm just mentioning this. How do we investigate? Well, we advise you go to one of the specialist units for this. We look at you, we examine you, and we do an MRI, which is on the left, and you can see we look feet upwards, so that's on the left-hand side, a lump in the neck. And PET scans look at the way lumps use sugar, glucose. And we can show that if something is growing rapidly, it uses more glucose. And you can see the lump, it's got green and yellow and red. And the red is the high uptake. So if a surgeon wants to work out whether this is a cancerous change, they can go directly where that red bit is and make sure they get the right answer. Can PET be wrong? Yes, it can. It's a guide. So it just helps us in trying to make this diagnosis, and it will be seen then in a very specialist unit. And there's a very good unit in Bristol with Adam Dangoor and his colleagues. Moving on swiftly to the eye. Optic pathway gliomas are common. You see them in about 15 out of 100 people, but only about 5% of those, of the 15%, need treatment, so very few need treatment. And with our colleagues in America, we found that really, if they were going to need treatment, the vast majority do so when somebody's under the age of 6 years, and usually within 3 years of diagnosis. So many of them don't need treatment at all, and we base the need for treatment on vision with some scanning, but the vision is all important. We never use radiotherapy. Do people know why? Because it increases your risk of cancer in this group that don't need radiotherapy. Radiotherapy is sometimes needed, but in this group, no. And we treat with chemotherapy. And when we looked at all our adults, who some have been treated in childhood, the vast majority of them have got good vision. So these days, we can do a lot. So what should you do to manage your vision? So young children may need their vision being checked every 6 months or so. And it's really good to get an eye doctor looking at the vision early on. We check at least yearly till 16 years, and after that, every couple of years, like an adult would do. Bearing in mind, people want to drive when they're 17, it's really important that the ophthalmologist or optician does fields, visual fields, so that's seeing, if you look straight ahead, you can still see out of both sides. And that's your visual field, so it's in front but the side. So if you're driving, you don't want to knock over a little old lady that's on your right, because you can't see on the side. And so visual fields for driving are really important. And these are the sort of tests. So when you're a baby, you are attracted to these lines. When you're a little bit older, you see pictures and then single letters, and then when you get older still, you can read the Snellen chart. And then, does anybody know what that thing on the right at the bottom does?
Colour blindness.
Pardon?
That's colour blindness, the number thing.
Yeah, it does. It's an Ishihara chart that looks at colour blindness. And then somebody's looking through a slit lamp to see if anybody's got leash nodules. So what about the subject of brain tumour? Well, the good news is they're common and they very rarely give a problem. Some do. So most of them are slow growing and they don't need treatment. And if you look at the one on the far left, it's squashing those white things. Those are ventricles. They contain fluid to bathe the brain. So that one did need treatment. But the same on the one in the middle, that one didn't need any treatment at all, and it was another family member. So it varies. Most of them do not need treatment. And then we get sent people with the one on the right, those big white blobs on the right. They're focal areas of signal intensity, white blobs that are harmless, and they're not tumours at all. So our advice is that if you get a symptom that's unusual for you, I mean, everybody gets the odd headache, but if you get something that's unusual for you, that's when you seek advice. And we used to not screen, but now, in company with all our other colleagues running NF units around the world, we offer screening of brain and spine, and some units do whole body, but we do brain and spine, at the age of 16 to 20 years. So what about bone? I told you that bone is quite important in NF1 because the gene, remember the recipe, helps our bone turnover, getting rid of old bone, getting new bone, and it's not as good in NF1. So the bones tend to be a bit softer. You tend to get lower vitamin D, although we have no sunshine, so we don't get much vitamin D anyway. And you get lower vitamin D, you get a risk of fracture with that. Because your bone density is a little bit reduced. So these are just some examples. Up the top is just a sort of hollowed out chest, which you can get even if you haven't got NF1, it's harmless. Lower down on the left is an adult with a bowing of the leg, which didn't really cause any symptoms. But this pseudarthrosis, it's a fracture of a bone, a leg bone, after very trivial injury. Somebody once fractured their child's leg by just changing a nappy, nothing to do with the parent, it was the condition. And it heals with a false joint, a pseudarthrosis, so it needs very specialist treatment. Some people get carving of the spine, as you see right at the top. And dural ectasia is something that's very common and some people get het up about, because all those white, I'm going to just walk over and show you, all this white stuff is dural ectasia. And what I think of the spinal cord as like a leg, and the dura is like the tights. The tights are protecting the leg, and the dura protects the spinal cord. And sometimes, like tights, it can go a bit baggy, and that's what we call dural ectasia. Most of the time it's harmless. Sometimes people get a bit of pain, and it's very rare that you need to operate on it. So what do? Go to the Seychelles and get some sunshine. Stop smoking, reduce your alcohol. It sounds very boring. Do some exercise. You can be like me and bore everybody in your unit and tell them that you're now doing ballet. Yes, it is true. And make sure you got calcium in your diet. What contains calcium? Milk, cheese, yogurt, strangely enough, kale and some very odd things. Oily fish, I wish it was, milk chocolate. Right, what about the associations? High blood pressure, we can all get high blood pressure, but some rarer conditions, a hormone-producing lump called a pheochromocytoma, or a narrowing of the arteries to the kidneys. So your blood pressure needs to be checked once a year at least. Has anybody come across Gliomas tumours? Yes. So what would you say the symptoms were?
Severe pain.
Horrible pain. So if you bash your hand, do you think somebody's hit you with a hammer?
Yes.
Yep. So they can come on fingers or toes. There's sometimes little purply changes under the nail. And if the doctor helpfully presses on it, you hit the roof. These are just bodies in the fingers and toes that actually control temperature. So they're harmless and they can be removed, and that cures it. But people sometimes get very het up and think there's something more serious. Now, breast cancer does increase due to the work of Gareth Evans and people. We found that it is increased in frequency under the age of 50. So we've now started, like everybody else, doing mammography screening at the age of 40 years onwards. So if you're not having that and you're over 40, you need it. So some more simple things. Headaches. If you've got a serious headache, obviously you need to go to the doctor, but many of us get headaches if you've gone to a boring lecture, if you've been up with the kids all night, if you've drunk too much, etc., etc. So what do? You get sleep, you relax, very difficult in these modern times, eat regular meals, cut caffeine, and yes, Coca-Cola's got a lot of caffeine in, and beware taking too many painkillers, because strangely enough, if you take drugs like ibuprofen, if you take too much of it, it can give you a headache anyway. So what about sleep? We would all like more sleep. You can get difficulty getting to sleep, disturbed sleep during the night, waking early, snoring heavily, or getting very annoyed because your partner snores heavily. So there are many, many causes of sleep problems. Sometimes people with low mood can't sleep. You can get medical causes like restless legs. You keep moving your legs around. Some drugs make you sleepy. And obviously pain can stop you sleeping. If you've got a partner who snores incredibly heavily, you can hear them down the block, they may have some minor obstruction and they need to go to a sleep unit to be sorted out. So you avoid all the things that you like in life, like alcohol, caffeine, looking at your mobile phone and computer. Don't play computer games an hour before going to bed. Don't look at the television, it's not fun. And try relaxation. In practice, these are very difficult to do. Do I practice what I preach? Never. But never mind. So finally, chronic illnesses really do require adjustment, not just NF1, but people with asthma, with diabetes, with epilepsy. These change your pattern of life. And so sometimes you need support. We all need support. So our nurses and the specialist advisors from Nerve Tumours UK and the nurses in Manchester, Oxford and Cambridge give support. They may help you with your clinic appointments or just supporting you through your issues, say your kid at school. They can provide support in the clinic, but also by telephone. If you're an inpatient in a hospital, they may visit you. Our lot run for local areas support groups, not just for young teenagers, but for older people, for parents. And there is this need to adjust to your illness and help with anxiety and depression. So I would say, despite the 20 doctors in our unit, we are very dependent on our nurses and Susie Henley, who's on the right. So if you've got any questions today, I'm sure Mary, who's right at the back, will be happy to answer them. So I will leave you with those thoughts.